Good evening, everyone. I am Dr. Najmah A Alsobahi. I am a general surgery senior registrar from Makkah Healthcare Cluster from Saudi Arabia. Actually, it's my pleasure to present in such informative conference and meet the expert in the field. So I'm gonna present a rare case, or actually a rare presentation of occult breast cancer metastasized to the GIT, gastrointestinal tract. So starting with our case report is about small bowel obstruction as first presentation of metastatic lobular breast cancer for Pilgrim patient. Introduction. The most common cancer among females worldwide and in Saudi Arabia is breast cancer. Invasive lobular breast carcinoma is the second most common subtype of breast cancer, considering that the first most common is invasive ductal carcinoma. Metastatic breast cancer to the gastrointestinal tract is rare. It accounts for 8% to 35% of the cases. Ductal carcinoma spreads to the liver, lung, brain, and bone, while lobular metastasizes to the gastrointestinal and gynecological tract. The differences in metastatic pattern between invasive ductal and lobular breast cancer are attributed to the loss of expression of the cell-to-cell adhesion molecule, E-cadherin, in invasive lobular carcinoma, which is related to the mutation of CDH1 gene. Case presentation. So our patient, she is 69-year-old female Indian Pilgrim. She presented to our ER complaining of abdominal pain for 3 days with history of nausea, repetitive vomiting, and she didn't pass stool nor flatus. She had complete obstipation for the same period of time. She has this as a first presentation, and on examination, patient was in pain. She looked toxic. She had tachycardia, abdominal was distended with severe tenderness all over the abdomen, generalized tenderness, and she has kind of guarding and rigidity with peritonitis. So labs revealed metabolic alkalosis with hypokalemia, which is a consequence of repetitive vomiting. Abdomen, we did for her abdomen X-ray, erect and supine. It showed signs of intestinal obstruction with multiple air fluid levels and dilated bowel. Mainly, the small bowel was dilated around 5 centimeters. So after that, we proceed with CT scan of the abdomen and pelvis with IV contrast that reported distended ileum. It was 5 centimeters. Proximal to the transition zone, which is in the terminal ileum, and distally the loop was collapsed completely, and also there was a few free fluid in the pelvis. So this is the CT scan. This is the sagittal view, which showed the transition zone. Okay. The patient after that underwent exploratory laparotomy after explaining the risk and benefit and after taking the consent. So in OR, she was found to have a mass at the terminal ileum with proximal loop dilatation and distally collapsed. And upon further exploration, there was multiple enlarged lymph nodes. So a small bowel resection of around 8 centimeter segment. The resected segment was 8 centimeter, which involved the pathology. Then side-to-side primary anastomosis was done to relieve the intestinal obstruction. As there was no perforation, no stool contamination, so we proceed with primary anastomosis. So this is the image showed the gross pathology, which is showing the lesion. It protrudes through the lumen. It was around 1.5 by 1.5 centimeter. And after following up with the histopathology, the microscopic description showed small cells with round ovoid nuclei, which lack the cohesion and appear individually dispersed through a fibrous connective tissue, and it was arranged in single file linear cords that invade the stroma, concluded as metastatic lobular carcinoma of the breast. So the lobular carcinoma was invading the muscularis propria in this case. So after following also with the immunohistochemistry, it reported CK7, cytokeratin 7 positive, ER positive, EMA positive, and CKAE1, AE3 positive. The patient had an eventful recovery, but the patient, upon her request, she wanted to travel to her country, so she was discharged against medical advice and traveled to her country after 2 days before even the histopathology result came, and she lost the follow-up with us. Discussion. Patients with metastatic breast cancer to the gastrointestinal tract often present with non-specific symptoms, including abdominal discomfort or pain, early satiety, nausea, and gastrointestinal bleeding. While acute cases present with perforation and gastrointestinal bleeding, however, intestinal obstruction was reported as the most common clinical presentation, like in our case. There was a retrospective review by Pilgrim found that out of 73 patients diagnosed with metastatic breast cancer, only 23 cases had gastrointestinal metastasis. Among these 23 cases, the majority, which is constitute of 45%, metastasized to the colon and rectum, 28% to the stomach, 19% to the small bowel, and a minor fraction, which is 8% to the esophagus. Among all metastatic systems, the luminal gastrointestinal tract is less common to be involved, and it is important to identify the difference between the different possible presentations for accurate management. Withington Hospital statistics used clinical and autopsy data showed that invasive lobular carcinoma has more propensity to cause carcinomatous meningitis and spread to the peritoneal, retroperitoneal, stomach, intestinal wall, and urogenital system more than invasive ductal carcinoma. That suggests a different pattern of metastasis for both breast cancer histopathology variants. And there is another retrospective review at Memorial Sloan Kettering Cancer Center. It reported 7 patients with metastatic breast cancer to the gastrointestinal tract. 4 of them had lobular histopathology, but only 1 had ductal subtype and 2 had mixed lobular and ductal features. So immunohistochemistry plays an important role and crucial role in differentiating between primary GI cancer and breast cancer metastasis. Markers commonly used are estrogen receptors, progesterone receptors, CK7, cytokeratin, and CK20. In our patient, ER and CK7 were both positive, which indicates distant metastasis. So the treatment of metastatic breast cancer to GI depends on the clinical situation of the patient. In case of emergency scenarios, when a patient presents with obstruction, hemorrhage, or perforation, palliative surgery should be the first line of treatment. However, for stable patients with multiple metastases, the mainstay of management is to follow with medical oncology, chemotherapy, radiotherapy, anti-HER2, and hormonal therapy according to the case and as indicated. Survival is determined by the stage at diagnosis. According to breast cancer statistics for patients diagnosed from 2009 to 2015 in the United States, the 5-year survival for stage 1 was 98%. For stage 2, 92% and 75% for stage 3, while it is 27% for stage 4. So I would like to conclude that breast cancer is the second most common cancer leading to death. The lobular subtype has more propensity to metastasize to the gastrointestinal tract compared to the ductal breast cancer. The different presentations of metastatic breast cancer to the bowel make its diagnosis and treatment challenging. For patients who presented in the emergency bay with intestinal obstruction, bleeding, and perforation, treating the emergency complaint is the standard of management. For immigrant patients, we highly recommend creating a data system for communicating with them and sending the histopathology reports with full surgical reports to allow them to follow up appropriately with surgeons in their countries. Thank you.